ahead and jump into it. I will say that we've made some changes in this particular course, kind of rearranging some stuff. And so I kind of lost track of what we were supposed to talk about today. Let me not say lost track. I was prepared to talk about way more stuff than I'm going to talk about today, because I didn't realize that we moved one of the lectures around. So as a result, I'm not sure I'll spend as much time as I can with these. So I'm not sure how much time we'll actually spend in class today. But again, I knew it was too much for 2 hours that we had before, so I was like, it's gonna be boom. Then I realized, oh my God, I can take this part out. So cool, I was able to take that out, so we can spend a lot more time here. So anyway, any questions that you have, I say that because there are a couple of things that I normally like to do in a lecture. But when I'm not given enough time, I'm like, let me just give you the basics. So the slides have the basics. What I like to do is throw in cases so I can give you some scenarios for you to do in class, kind of a thing to help activate it. And so there are no scenarios or cases in here, and I normally like to do that. But what I'll do is I'll make sure I point out certain things that you'll do in making a decision for these therapies, okay? As a result, there's homework. Huh? Hey, it's always for a grade. It's always for, I don't do anything for nothing, right? It's always for a grade. There's homework. So the homework, actually the homework, in my opinion, is pretty straightforward. I'm not gonna say simple, but what it should do is reinforce what we're gonna talk about today. It's some of the go home, put all of this together, kind of get your mind around how we individualize therapy. Again, it was because I didn't think we were gonna have time in class to do it. So anyway, we'll do it that way. Next time I'll make sure that I can put some scenarios in. So today we're going to talk about menopause and osteoporosis. Before I jump into it, any idea of why I'm talking about it in that order? Menopause, then osteoporosis. Menopause leads to osteoporosis?
Because of decreasing estrogen.
Okay. So, can I get osteoporosis?
You can't go through.
You said I can?
You can't go through menopause.
But I can't go through menopause. So you jumping all ahead. I'm saying, like, if menopause leads to osteoporosis, you just told me I can give you
Contribute to this.
I mean, I can get osteoporosis. I can still get it without menopause.
Yes. Drug abuse.
Man, I thought you were gonna tell me I couldn't get it. God, so yeah, it could happen. Drug induced only? I can't get it.
Age.
I can get it naturally.
Age.
Age?
Yeah.
What does that mean? When I hit a certain age, it's coming?
No, when you get older.
Happy birthday? It's what? It's an effect of aging. As I get older, I can go ahead and put that on my chart. Future medical history, not past. Future. Okay. All right. Well, I'll talk about it more. Nicholas, you're on the right track. Certain therapies that we'll discuss today that are used in menopause actually are effective in preventing osteoporosis. So one of the things that, I'm gonna assume, and I hope this is a good assumption, but I'm gonna assume that you guys have at least been exposed to osteoporosis already. So one of the things that really I'm focusing on really is postmenopausal osteoporosis. Not necessarily, the whole gamut of osteoporosis. So what that might mean, as far as the pathophysiology, it's the same. But what it might mean is some of the medications that you see that we're going to talk about, you're like, hey, he forgot a few things, you know, because we're not really talking about osteoporosis by all causes. Just those that are associated with postmenopause phase. All right, so let's get into menopause. I want to tell a quick story before I do this because none of you guys, you know, maybe some of you are thinking, I don't know. You all right?
No,
I know, that's what I'm saying, you know. We still not, you know, they coming up with new variants. That didn't sound good. You know? We all trying to, you know, get back to normal. I don't know. And she up close, you know what I mean? Just jump in close. I need to put it back on. So anyway, you got me off track. I was telling my good story. All right, so my good story is this. What you laughing at? Some of you might be thinking, at least 20 years ago, they were thinking this. Can a guy talk about women's health? You were thinking that? You are?
because y'all don't understand the struggle.
Because we don't understand the struggle. Anybody else? Daniel just laughed. He's like, I was thinking that, man. I didn't want to say that. So why he didn't get, well, all these female professors, why he up there talking about women's health? We don't understand the struggle. Anybody else? I like all of this. I'm glad I was going to tell my story. Yes. You say no? Okay, all right. So when I was in pharmacy school, and we were talking about menopause, actually, when I was in pharmacy school, it was a little bit different. So I know that I was exposed to menopause. Well, actually, we took therapeutics like now in our third year. Yeah, we only had 2 classes. So this is after everything. You know, we took pathophysiology, all of that kind of stuff, pharmacology, we took all that. So we were exposed to the medications, not necessarily the disease state. So I heard of the drugs before. And you know, just like any young, stupid male, not all young males, but young, stupid male, I'm like, I don't need to know that. But I'm a pharmacist for all patients. But I'm like, hey. Female stuff, By the time I got to therapeutics, something strange happened. My mother was going through menopause. Now it was early. It was surgically induced. But I was like, what in the world is going on? And we started talking about menopause and therapeutics, and I'm like, I need to know everything about this. I was like, probably the most attentive I've ever been in class. I'm taking every note, because I'm trying to figure out what in the world is going on. So just like Farrah said, I went through it. Maybe not myself physically, but boy, emotionally, psychologically, and everything else, it stuck with me. So as a result, when I graduated, and some of the things that we're going to talk about today, the largest trial in history, actually even to date, was being conducted and actually stopped. This was during my residency. So they were like, hey, can anybody go up and talk about hormone replacement therapy? Let me do it. And I did, very well received, and I actually got invited to talk about it at a national conference. So I'm like, I thought guys can't talk about this. And it was so interesting because so many women, now I'm in my 20s, so all of these women were older to me than my parents had. So I'm like, these older women, all these older women, excuse me, I need to talk to you. I've been wanting to talk to somebody about this, and I'm like, wow. We weren't doing this at Walgreens. So this was amazing, at least at that time. So that was the impact of this study and what we learned at that time. That's 20 years ago. But we learned a lot about hormone replacement therapy with that massive trial. Those findings, of course, we'll talk about today, and some of the updates, you know, that we've had since that time. All right, so let's just get into it. So yes, men can experience it. They can go through it, they can pay attention, but even if you don't experience it with, you know, a parent or a spouse, you're gonna have patients that you're gonna have to take care of. So guys, pay attention, all right? All right, so 95% of women will experience menopause between the ages of 44 and 55. You can look at some other ranges. Some people say, well, it can happen as early as 40 and it can happen as late as like 58. So there's a larger range than that, but that's a small percentage of time when that happens. So the sweet spot is 44 to 55. On average, you're talking about 51 to 52. That's when you're gonna normally see this. So there is a technical definition, and of course that technical definition is amenorrhea for 12 months, right? So that's what you're looking for. There is, of course, a time when you need to know when that final menstrual period took place, okay? And then, of course, 12 months later. There are a couple of things that this right here on your slides, put an asterisk by this. This is what you need to know. Because really, for the most part, this is diagnosed by symptoms. I'm gonna talk a little bit about lab tests that are done, but whether those lab tests are positive or negative, if the symptoms are positive, hey, menopause, okay? So remember the symptoms that can take place. Two of them that I will definitely highlight because they are used in individualizing therapy. So when you're individualizing drug therapy, so I'm gonna underscore that again. Okay, let me stop for a second, because when I say individualizing therapy, some people start blinking their eyes because they're like, oh my God, he talking about individualizing therapy. I heard him talk about individualizing therapy before last year. This is not about kinetics, okay? We're not individualizing therapy based on kinetics, okay? We're individualizing therapy based on their symptoms, and we're individualizing therapy based on their risk-benefit profile, okay? And I'll talk a little bit more about the risk associated and what the benefits are, but basically that's why we're individualizing therapy. When you look at risk, I don't want to call it risk, I just call it side effects. So their risk-benefit, we'll talk about risk and benefit later, but also side effects that they are experiencing from the medication, okay? So we might be trying to treat some symptom, but because of the medication, it's causing certain side effects, so let's change therapy. So that's basically how we're individualizing. So you have to know what symptoms we're trying to treat, because how do we know that the drug is working, right? So our goal is not a situation where we're monitoring hormone levels, or I can come in and take a lab. I'm looking for symptom improvement, right? So I need to know what the symptoms are. All right, so two things. All of these are certainly possible, but I want you to put asterisks by these two, okay? So vasomotor instability, what am I talking about? Hot flashes and night sweats, right? Of course, the vasomotor instability leads to sleep disturbances, but you can also have sleep disturbances without the vasomotor symptoms, okay? Genital urinary atrophy, what are we talking about?
Is your uterus inclined?
When they come in,
The muscles?
what kind of symptoms might they describe? Dryness, pain, dysuria, pain during intercourse. So it's not what it's going to be called, right? But look at what side effects will occur, because of course that's going to be a target area for certain medications and symptom improvement. All right, so take a look at that. There are lab tests that are run, but as I mentioned, You expect an increase in FSH, but even without an increase in FSH, you will, with the symptoms plus the absence of menses for 12 months, you will diagnose that as menopause. All right, I won't go through the staging, but I wanted to at least have them included for you because you may see, depending on what environment you're practicing in, you may see the staging system, but you know, I can tell you, in most cases, it's not necessarily very common to see a staging with this particular disease state. It is important though, in general, so I won't talk about it specifically, but it is going to be important for you to understand at what point are we in menopause, okay? And I'll talk about it a little bit later. Not necessarily again from the staging standpoint, it's just how long are we in this particular phase. In general, how long does menopause last? Ooh, that's a good multiple choice question right there. In general. I'm gonna take a guess.
A year?
A year? Ooh, I wish.
Longer?
Yes, you didn't do the pre-read. Huh? Huh?
5 years.
5? You're gonna go with 5? I feel strong about 5. I don't feel that strong about 1. But I feel like 5. You gonna say 7? Why you going up? Ain't nobody gonna go 3. You gonna go 3? All right. Final answer, anybody?
I feel like it's something new way to you. I mean, yeah, it depends, but even though you're trying to get rid of the symptoms, there are certain stages that probably women will be experiencing those things for a while. I don't know.
Yeah, we said a while. We said 1 year, 3 years. That's a while, right? I need you to define a while. I don't know.
I mean, these are gospel. I mean, there's all things that are gonna come through based on it.
Now, menopause and osteoporosis is not the same.
Right.
Okay.
But there are things that eventually lead to it because we are.
Yeah, but they're not the same.
Okay.
We're just talking about menopause. We're talking about these symptoms that are being experienced. So 10 years. That's the normal period. 10 years, yes. Yeah, and so as a result, you know, some people are thinking just like you guys, I can tough this out. It'll get better. There are certain things that do get better. 5 years in, you're like, man, this didn't go away yet. Let me go see somebody. Right? So this is really normally a 10-year trip. Okay. All right. So, oh man, I messed up. Let me skip around just a second. This is again. I want to see. Did I delete this? I think I deleted it. Oh, no. I meant to move this up. Talk about non-pharmacological before we talk about pharmacological. There are some things that you can do. So like I said, you know, before someone jumps in and receive treatment, you know, they're not just saying, hey, I'll just tough it out. They may make some adjustments. Do activities to reduce core body temperature. What might that be? If you're hot, what are you gonna do?
Drink cold water.
Drink cold water. Cold shower, yes. What else? Once you get out of the shower, turn the AC on, a fan. Telling you, y'all bring back memories. Ice packs, yes. Yes, ice packs, yes. It's there. I just skipped forward.
It's on 31.
It's 31? Yeah, it's there. I just skipped forward. I meant to put this up front, then I'll go back. Smoking cessation is also a lifestyle change that should be used. Actually, depending on the age, hormonal replacement therapy for someone who's smoking is actually contraindicated. So you certainly, that is a lifestyle change that you certainly want to employ, even if the person is going to use hormone replacement therapy. Weight management, there's normally an initial 5-pound increase of weight gain during the initial menopause. So weight management is important. I can tell you nowadays, there are much more relaxation and breathing techniques than there were prior, but yes, this can be a very, very difficult situation without them. So there are some non-pharmacological things that you can do. Certainly, go back where was I at? There we go. But certainly, there are some pharmacological treatments as well. I will say this, when you're looking at non-pharmacological treatments, this is not a situation where any of those things that I talked about are things that will treat the symptoms. Okay? And essentially, I won't say cure them, of course, because if you stop the medication, they're coming back. But certainly help reduce or minimize the symptoms as much as you can. None of them are as effective or near effective as pharmacologic intervention, okay? So for most patients, either they're just not going to take medication and they're gonna ride that 10 years out, or at some point they're going to take medication. So we have 3 different approaches, at least on the hormonal side. Essentially what you're looking at is estrogen and progestins. So either in combination, where you have estrogen and progestin, or estrogen alone, or progestins alone. All right, so what I'm gonna do is I'll talk about the combination therapy first. So again, when I was talking about the WHI trial, and I'll talk about it specifically, these were the 2 medications that were used, but we're talking about really a what's called a cyclic and sequential type strategy versus a continuous strategy. What do I mean by that? Cyclic or sequential versus continuous. What's the difference in these 2 medications? I mean, they both start with a prim.
You take breaks with one or the other, you just take it nonstop.
Say it one more time.
With the cyclic, you take breaks in between, you're not constantly taking it every day. And actually with the continuous, you just take it all the time.
No, you take them both daily. But you were correct, then you're taking a break. You're taking a break from what? Huh? So, yes, the amount of estrogen and the amount of progestin are not the same. So, in a continuous strategy, so in the PrimPro, the amount of estrogen and the amount of progestin are the same. In Prim phase, that's not the case. Okay? So, you have a change. And why do you have that change? What is a normal estrogen progestin? Like, I don't know yet. We haven't talked about this yet. That's true. You're going to talk about it next week, especially when we talk about contraception. But again, you're manipulating estrogen and progestin in that particular case. So you'll probably understand it a little bit better after next week. But it's the same strategy that you're looking here, where you're changing the amount of estrogen and progestin. So just those 2 different strategies that you're going to look at with combinations. All right, so let me just talk a little bit more specifically. And some of this, again, is just general information, but I'll kind of highlight some things when I talk about it in the future. But it used to be just these bottom 2 strengths. The 0.625, 2.5, and 0.6255. Those were the options. We certainly learned that later that you need to reduce the amount of estrogen in some cases because of risk, because of side effects, and also reduce the amount of progestin. Of course, it was studied, and it was found that, excuse me, that at least the vasomotor symptoms, when you make that reduction, it's equally as effective. So you want to look at this for really more side effect management, okay? But it does decrease your risk, okay? We'll talk about risk a little bit later. As I mentioned before, when we're looking at, Prim Pro. What did I say earlier? This is a continuous strategy, right? So it's the same amount in all tablets, right? Whereas in Prim Phase, that's not the case, right? So we have 14 of the tablets where it's estrogen only. So unopposed estrogen, no progestin. And then the other 14 are progestin tablets. All right, so we mentioned symptoms, right, that you would have that are associated with menopause. But of course, any medication that you're going to take will have certain side effects. And as I mentioned before, you're going to evaluate these side effects to make decisions as to what changes you might make. So abdominal or stomach cramps, breast tenderness, most of the side effects that are listed on the more common side are associated with estrogen. Okay? So if you had someone, let's say, with breast tenderness and they were on the 0.625, you could reduce the amount of estrogen that they're receiving in this combination therapy. Okay? I did list here, so all side effects aren't necessarily equal, right? So if you're experiencing any of these side effects, this is actually something that you will want to speak with the physician about. Now, of course, speak to the physician about this is also something that you want to know about as the pharmacist, right? So when you're explaining any of these side effects, make sure the patient lets you know that they're experiencing this. This is more package insert manufacturer recommendations of, hey, the physician should be contacted for these things. But that's really under the guise of, hey, if these things happen, why do you think you should contact the physician? Patient's gonna die from any of these? No. So it's not like an emergency where you need immediate medical attention. So it's not contacting the physician in that way. But really, we're saying the physician needs to be contacted because you need to make changes in the therapy, okay? For these, not necessarily. Some of these symptoms may resolve. Some you may have to adjust the therapy, but certainly here, we have some other therapy that we can use if patients have any of these types of side effects, okay? Does that make sense? All right, and we'll talk a little bit more specifically about what some of those options are. All right, so we talked a little bit about combination. I told you there are two options, right? So estrogen only, when we look at estrogen only therapy, and one of the things that I want to make sure I highlight is that there are different dosage forms, right? So it's not just oral medication. These are certainly different dosage forms of estrogen that you can receive. There are really 4 forms of estrogen that you'll see. So I included what that estrogen content is and what some of the brand names are for those particular products. Estrogen only. So remember, as I mentioned earlier, a lot of those side effects really are associated with the estrogen. So the nausea, the headaches, breast tenderness, heavy bleeding, and I'll talk about that a little bit more, are very common side effects of of estrogen. I did also include here of some modifications that you may want to make. Okay, so remember on the left-hand side we talk about, hey, if you had any of these, you can make some adjustments, and those adjustments really are in dosage form on there. Of course, if we aren't going through the GI tract, you're going to reduce the amount of nausea. You still may have some nausea, even with the transdermal, because there is systemic absorption and circulation. You also will have reduced headaches associated with it and breast tenderness. Okay. Now, of course, transdermals aren't without their own unique issues as well. So, skin irritation is associated with transdermal administration, where it is not necessarily associated with oral. All right. So, targeted symptoms where we would have treatment. So I talked about these here earlier. Remember I said there's really two. I'm going to break out three here that you may have some targeted treatment. Okay. So when you have genital urinary atrophy, this is now I don't think I highlighted it before, but let me highlight it now. It's in the slide somewhere. I may have just skipped the bullet point or something. But I do want you to know, when we're talking about hormone replacement therapy and we're talking about these symptoms, you normally have classification of symptoms, right? Mild, moderate, severe, right? When are we using hormone replacement therapy? Hey, you got a 33% chance of getting it right by just guessing. Mild, moderate, severe. You want to go with severe, right? See, like severe, I got severe. You gonna say mild? Somebody say moderate. Moderate to severe? Okay. All right. 66% chance getting that right. All right. So moderate to severe. So for mild symptoms, you're not using hormone replacement therapy. Okay. We'll use some non-pharmacological therapy that we'll use. Okay. Even for genital urinary atrophy, there are some lubricants and different vaginal creams that you'll use that are not necessarily hormone replacement therapy. So non-hormonal. And I'll talk about some options a little bit later. But when you're talking about hormonal replacement therapy, you're looking at moderate to severe. Okay? All right. And I gave you one of my answers. All right. So when you're only having vaginal symptoms, okay? So this is not vasomotor symptoms. So this is just, we're dealing with just vaginal atrophy. You're really looking at a vaginal dosage form, okay? So you're not really necessarily using an oral dosage form here. Your vaginal dosage form is recommended, okay? So you can use vaginal dosage form even for painful sexual intercourse, but there's also a non-hormonal option that I'll talk about a little bit later. I didn't want to give you that right there, but I did. All right, so what are those dosage forms? Somebody jamming up there. Estrogen therapy. So ET is estrogen therapy. So if you see ET, that's estrogen alone that we're talking about. If you see EPT, that's estrogen and progestin therapy. And if you see PT, that's progestin therapy. Okay. All right. So here are the dosage and the frequency that you would use for just your genital urinary type treatment. I mentioned this earlier. How does this drug work? How would you classify this drug? I think there are two hints on here. One is the generic name. I'm not gonna have you draw the structure, but that structure should be similar to some other medication that you may have learned. And you should see here, it's an estrogen agonist and antagonist. So how would you classify this drug? I'm not hearing anybody, so maybe y'all haven't learned these yet.
You know it was mental health day yesterday.
I didn't ask you yesterday. Like, you know it's mental health. Yeah, I know. I ain't asked you anything yesterday. Yeah, anything for me. Huh? Yeah, that's true.
It's in the category of SHRM,
Okay, what does that stand for?
selective estrogen receptor modulators.
Okay, all right. So yes, you're gonna see other medications in this category that selectively, so that could be confusing. So that's why I said think about the category that it's in. It modulates the estrogen amount, so it can agonize the receptor or it can antagonize, depending on how much estrogen is there. So yes, that's right. So for painful intercourse, this medication is a non-hormonal that could be used in place. Again, it's not indicated for mild symptoms, okay? Just moderate to severe. There is, even though it is not a hormone itself, it does affect estrogen, right? So there is still a thrombosis risk, okay? Just like there is for estrogen. All right. So I mentioned I'll break out two of the vaginal areas, but I kind of combined them earlier. But if you're having atrophic vaginitis, so this is also common as well. It's saying here only 20 to 25% seek treatment, but how many people experience this? It can be anywhere from 25 to 85% of the people, so it's a wide range. So it could be as common as vasomotor, but in those particular cases, kind of that overlap is people that have both symptoms, so vaginal symptoms and vasomotor symptoms. So a small percentage of people that just have vaginal symptoms only and no vasomotor symptoms. All right, so again, as I mentioned a little bit earlier, these are some of the symptoms that you will hear that the patient is experiencing. And again, your goal is to reduce or eliminate those symptoms, okay? I kind of alluded to this a little bit earlier. So we're gonna assess the symptoms and how severe they are. And we're going to target improvement. It says 1 week, but it's normally 1 to 2 weeks. Let's just call it that. You'll normally have a follow-up period when you start the initiation of therapy at about the 6-week mark, okay? So again, this is just for counseling purposes. Hey, I'm using this. When should I see improvement? 1 to 2 weeks, okay? But we'll have a follow-up visit in 6 weeks, okay? So remember that. What about vasomotor? These are the ones that are most common, right? I talked about it earlier, hot flashes, night sweats. These are, it says several times a day, and usually during sleep. What is several? What do you think several times a day is?
They're just always hot around the clock.
Give me a number. You said what? You said 2.
I said four.
More than once.
No.
Several is more than one. If I give you several dollars, boy, you're
More
gonna
than
order more.
7 instances.
How much?
More than 7 instances.
More than 7? 4 to 6? Up to 20.
Yeah, I've seen it. They always hot.
Yeah, up to 20. So, Yeah, 4 to 6 could happen, but you're like, oh my God, 10 to 15, yeah, up to 20 times a day, it could occur. So 20, don't remember 20. Like he said, it happened 20 times. No, that's not the common. But sometimes several can be misleading. Just as 4, it can happen a lot. Okay. Again, our treatment strategy really, we're talking about moderate to severe, and of course you can use combination therapy or estrogen alone. Okay. Before I go to some of the non-hormonal, I want to kind of have you think about something. Well, I'm going to give you some information, then have you think about it. All right. So the first thing I want you to realize is one of the things that you're doing when you're triaging whether or not I'll use estrogen therapy or estrogen and progestin therapy is whether or not the patient has had a hysterectomy or not. Okay? Because unopposed estrogen or estrogen alone can lead to endometriosis, endometrial cancer. So we want to make sure, but there are certain risks associated with estrogen and progestin too, where it may make sense, for us to try to target estrogen alone. So in a patient that has not had a hysterectomy, what do we want to use?
Do you want to use a
Get a
combo?
little bit loud. Turn it up. You got 50-50, right? Huh?
You want to use a combo?
The combination.
Yeah.
So in a patient that has not had a hysterectomy, you want to use the combination. In a patient who's had a hysterectomy, estrogen alone. Okay?
Is it because they don't have a uterus?
Right. You don't have to worry about that, right?
Okay. So is the progestin is because you want to be able to line up the uterus? That's why we add that in the combination, so they can still be able to have a period? Or what's the essence of it?
Okay, wait a minute now. So remember, we're talking about menopause. So the
Yeah.
period is paused,
Oh,
right? But in your normal physiology, like what you're describing, in that last 7 days, that's really the period, the time period, excuse the pun, where you have progestin,
Yeah.
right? So while you may not have menses during this particular time period, you do have hormonal secretion, or should, right? There are some beneficial or protective effects that progestin has to the uterus, right? So if you take that away, now you are going to have issues, is what I'm saying. But so that's why estrogen alone is not the right strategy. Okay, you want to use the combination. So good question. There's also SSRI that's used as a non-hormonal for moderate to severe vasomotor effects. Yes.
Just to go off what you were saying, Autumn, so the progesterone is added to kind of keep the hormone space to the body, and the estrogen is what's using treatment, in a sense.
Yes. Yes.
what did he say?
He's saying that you're saying that in order to treat these symptoms, estrogen will do it. Progestin is added as a benefit because that's your normal physiology. And the answer is yes. Estrogen by itself will reduce those symptoms. Yes. All right. Paroxetine. Is that used for anything else?
Yes, depression.
All right. All right. Not by this brand name, okay?
No.
All right. So this brand name is specific for vasomotor symptoms. Oh, I didn't mean to do that. I meant to ask you that question. What's different about it? The dose.
It's low.
What's the norm? Huh?
It's low.
It's low? Anybody say it's high?
Like 1 and 2.
Huh?
Pretty high.
This is high?
It's not high.
This is not high.
It's
I got a high and a not high.
It's
Yes.
not high at all.
It's not high at all?
No.
What's the normal dose?
20 to 40 milligrams across. 10.
It depends on which dosage form you're using. So you have the regular immediate release, you have the controlled release, right? So it could be 10 to 20 of immediate release, or 40. You can go up to 40, yeah. But I'm just telling you how it comes. And then your CR is 12.5 to 25, you know, and you can go up to 50, you know, in the CR. So this is a different dose, you know. That doesn't mean that you can't use those others, right? But it's at a lower dose used for vasomotor symptoms. But we do know paroxetine is a 2D6 inhibitor. Where is this problematic and what we're describing? So think about two drug-drug interactions, one with warfarin and one with tamoxifen. So those are two that you need to remember. That if you're using paroxetine, you don't want to use warfarin or tamoxifen. Of course, with warfarin, I mean, this is an enzyme inhibitor, so what does that mean?
It can cause accumulation and cause toxicity.
It can cause accumulation.
It can lead to toxicity.
It can.
It will.
It will.
Yeah.
Not always, right? It just depends on if the drug has an active metabolite, right? Or not. Am I right?
Yeah.
If a drug has an active metabolite, what does that mean? Once it's metabolized, if it's metabolized into an active drug and you inhibit that metabolism, will you have toxicity?
Yes.
You will?
With the active.
No. But if it is a substrate, right? If it uses that particular enzyme in order to have its effect, or I'm sorry, if that enzyme, I wanted to reverse what I was saying, if that enzyme is what deactivates that particular medication, right? And you block that deactivation, then you have toxicity, right? So this is what's happening with warfarin and tamoxifen. If we block this enzyme, and this enzyme is what turns that drug off, in the case of warfarin, you're gonna have more bleeding, right? It's gonna last for way longer than it normally would. Problematic. Is warfarin narrow therapeutic or wide therapeutic?
Narrow.
Very narrow, right? So any adjustments that you're making that's messing up the warfarin, you know, you're like, oh, this is a normal dose, but wow, look at this INR. The patient, in most cases, you don't even see the INR first. They come in bleeding. Then you check the INR, like, oh my God, here we are. So this is a no to give those together. All right, a couple of other ones. Oh, the answer was right there on the other slide. Is that why you were smiling, or you already knew?
No, I already did.
You already knew? Okay, but I put the answer here. You know. But you can also use clonidine. So you may see clonidine that's used for vasomotor. Of course, clonidine has its own side effects as well. What kind of medication is it? SNRI. So SSRI could be used as SNRI, could be used venlafaxine. Gabapentin is also an option.
Nerve pain?
So I actually read about this clinical trial. It said that venlafaxine was the most effective, but it didn't really explain why like citalopram wasn't used.
That's a good. Now, you're saying citalopram?
They said like specifically citalopram and I believe fluoxetine weren't particularly used in this trial, but venlafaxine was proven to be most effective.
How does citalopram and fluoxetine work?
last longer in the body, well, fluoxetine lasts longer.
I'm saying, how do they work though? What neurotransmitters do they work on?
Serotonin.
Right, so those are SSRIs. So are you comparing those here to paroxetine or to
They
venlafaxine?
just used a bunch of different ones, SSRIs and SNRIs.
Oh, period. So you're saying why were some effective and
Right.
others
Others
weren't?
weren't.
You know, that's interesting. I would have to go back and look at it. What I can tell you is that some of those profiles aren't the same. So when you, well, one of the profiles that you're looking at, remember what we're having, and in these patients, you're having, in some cases, sexual dysfunction, right, due to genitourinary problems, and some of those cause some of those problems. So you may not want to use that because it's not going to prove effective as one of the side effects, right? So some of it might be side effect profile. Other things, you know, the thing about when we're talking about, even when you're talking about depression, okay, so forget some of this off-label stuff. When you're talking about depression, all SSRIs don't work. You know, you try one, see if it works. If it doesn't work, we try a different one. Wow, this one worked. What's happening different? You know, so unfortunately, when you're talking about, you know, manipulating, you know, your neurotransmitters, just because a medication works on a particular neurotransmitter doesn't mean that it works the same in all patients, you know, and at the same doses. You know, that's just one of the, I hate to say that, but if we were up here talking about depression, that's what I would be telling you. You know, even when you go through the guidelines, you know, you're like, hey, I want to try this particular drug. I may escalate the dose, but if we're not seeing at least partial improvement, why am I escalating the dose? Throw this out, get another one, or add another one. You know? So that's basically, you know, what you're looking at. So when you're looking at things like this, you said the right thing of, hey, what did the study say? Because really, this is not always something that you'll be able to explain mechanistically. Unfortunately, you looked at the studies, this one worked in this particular scenario, this one did not, even though they have the same or similar mechanisms of action. So good point. Another point to think about that, and I want to kind of underscore this for a second. Don't make assumptions, right? And here's one of the things where clinical judgment is very, very important. And I often tell pharmacists, so are you the pharmacist, or is your computer the pharmacist, or the insurance company? Something to think about. Because when you go in and they tell you, oh, this medication is non-formulary, or it's, well, most of the time it'll be either a non-formulary or, you know, require some kind of authorization. Not for that particular drug, but I'm just saying we're just using it as an example. And sometimes it'll give you a recommendation. Use one of these. Well, if it's for vasomotor symptoms, not necessarily depression, does that recommendation make sense? I'm gonna just switch it over to this one. It should work too. Not if it's been shown to not be effective, right? Well, that's what the computer said. Well, that's when you have to know more than the computer. The computer's just pulling up what SSRIs are available. It's not necessarily looking at indication, okay? So this is one of those cases where you would call to get it approved because this is the one that works, okay? That makes sense? I will say that the study did not necessarily show, while it did show 7.5 as an effective dose, it didn't say that 10 milligrams wouldn't work, okay? So if you replace it with the generic 10 milligram, it will probably work as well, okay? So again, you gotta be smarter than the computer. All right, the computer is your friend though when it works though, okay? All right, are there alternatives? So are there some non-hormonal replacement therapy? I think as a pharmacist, you have to know that these exist, right? Some of them work. In some cases, some people swear by them, you know. But what I will tell you is that when you look at phytoestrogens, are they estrogens? Do they exhibit estrogen-like effects? Yes or no? 50-50. You got it.
Yes.
Yes. So sometimes people are, well, I'm not taking estrogen. Yes, you are. You're just taking a plant-based version, not a synthetic version. But you are taking estrogen. So it gives 60 grams of soy or up to 120, depending on what you're taking. Has shown to be effective. Here are some other herbal products that have been used, but what I really want you to underline is demonstrate small benefit. So does this say that it does not work?
No.
Says it works a little bit, maybe not as effective as some other therapy, but it does work, but it does cause toxicity, right? Some people think, oh, it's herbal, I can take as much as I want, I'll be fine. Here's where you want to really look at a risk benefit, okay? It doesn't work as well, and it could cause toxicity.
So if a person has like liver damage, you can
Well, even if they don't. Yeah, so certainly if a person has liver dysfunction already, they want to stay away from this. But this doesn't say that I can have a normal liver and it still can cause toxicity. Okay. One of the things that, for my perspective, some of you may be thinking, well, I don't need to remember this because I'm never going to recommend this for my patient. And some of you look at it and say, oh yeah, I'm going to recommend this for my patient. That's all personal preference. But all of you need to know it because let's say you have a patient coming in and they had elevated liver panels. You're reviewing their medications. So this is kind of when everything becomes real. All right, anything else you're taking over the counter? These are the things that you're listening for. Okay? Because people go to Dr. Google, right? And say, oh, this is good for this. I want to try it. And they go and try it. What's the problem with small benefit? They take more, right? It's not working. I feel like it's working a little bit. If one is good, two is better. This is natural. So I'm going to take 2. Girl, how many you try? I'm up to 4. Right? Okay? So, you got to think about that for a second. That people try this, they have access to it. So you need to know, even if you don't have the mindset that I'm going to recommend this, some of you do, and that's good. I see pharmacists all the time say, hey, before we get to the prescription medications, let's try some of these over the counter, medications that are available. They do work, we'll see, if this works for you. And if it doesn't, then we'll try some of the other things. But I just don't want any of you to think that, number one, I don't want you to think they're evil. Okay, come on, we go by the evidence, right? Evidence is showing that it's not evil. But the other thing is, just because everything has a risk and a benefit, and just because it's herbal or over the counter does not mean that it does not come without risk, that it's innocuous or whatever, because that's not the case. Even though patients think that, hopefully none of you think that, okay? You know that it comes with risk, okay? I saw a hand or something.
So for the phytoestrogens, can you recommend those in patients, because it does have an estrogen biologic activity, can you recommend that? Or should you not recommend that in patients who have history of like DVT?
Correct. Yeah, because it's going to have a similar risk. Maybe it's not going to be exactly the same because, again, we're maybe talking about the amount of estrogen that you're using. But I'm going to talk to you about cardiovascular risk here in a second. You want to include it in the same kind of profile. Because if it's somebody with low cardiovascular risk, you're probably still okay. But if they have higher cardiovascular risk, then you want to avoid it.
So
Okay?
what about like hormonal DVT, like DVT during pregnancy? And stuff like that?
So a good point. So you, typically during pregnancy, you wanna stay away from hormonal replacement therapy altogether.
Well, no, I'm saying if the DVT occurred during pregnancy. So like it was only because the patient was pregnant.
That's still, a patient that has had a DVT, even if it was because of pregnancy and not something else, are still at risk for it. You're saying just because they're not pregnant anymore, that risk is gone now? Is that the question?
Well, no, but what's up?
No, I'm saying that because that's not the case. That's not necessarily the case. Somebody has a DVT, even if it was associated with pregnancy, they're still at risk. So that's probably somebody that. But again, we'll look at the whole risk profile. You know, if you're saying, hey, they just had the issue when they were pregnant, has had no other issues, all of their other risk factors are low, then I would still put them in the low category, which means that they're okay. So again, it's looking at everything kind of in totality. Let me skip ahead a little bit. I need to see where I'm at on time. Okay, all right, so I got a little bit of time. All right. So I wanted to at least put something here about bioidentical hormone replacement therapy. You'll see, there was a time when you saw a lot of this, especially coming out of compounding pharmacies. You know, reimbursement and all of that kind of stuff has changed over the years. So sometimes you see it, sometimes you don't. But there are bioidenticals that are out as well. The only point that I wanted to kind of talk to you about, because I want you to be aware, you know, especially some patients may come talk to you. The only thing that you have to be careful with is it's not a standardized or regulated practice. So even, you know, product to product, place to place, you're really not 100% sure of how much is in there, okay? So a lot of times what normally happens, and especially in kind of the compounding or specialty type pharmacy space, like some of them go through a lot of certification and other things where, you know, they're basically have the same kind of testing in place that manufacturers have. So, you know, they can show equal rates for all of the products in their line. So, but everybody, just because they say, hey, this is what it is, may not necessarily be that particular case. All right, so I said, hey, let's talk about some of the clinical work. In these slides, I only focus on the WHI or Women's Health Initiative. That's not the only trial. I have some sources on some other ones too that have come out, but they basically came out after this trial to look at some very specific things that, again, I gave you the guidelines for, but that's where it came from in the guidelines. So as I mentioned earlier, they were looking at combination estrogen progestin therapy, and that the trial was stopped. So this is one of the largest trials in this space, and one of the largest trials, period, but certainly in this space, and it had to be stopped just because of incidents. All right, so what did we find? So I talked about risk and benefit. All right, so let's first talk about the risk. Well, what they saw, and the reason why the trial was stopped, is that in this combination therapy, increased risk of breast cancer, increased risk of these cardiovascular incidents that I talked about, so stroke, heart attack, blood clots. This is where we learn that particular information from. Of course, in estrogen alone, stroke, VTE. So of course, in this estrogen plus progestin type of therapy, the cardiovascular side effects really are attributed to the estrogen, right? They did see some benefits, so don't memorize, oh, these hormones cause cancer. because actually that's not necessarily true. Of course, in the combination therapy is associated with breast cancer. So in a patient, who has breast cancer or at high risk, you don't want to use the estrogen and progestin therapy. But it did show some benefit in colorectal cancer. So the patients that were on estrogen and progestin therapy had lower incidence of colorectal cancer. It also showed benefit in fractures, which is, I think, what Nicholas was talking about earlier. So because of the benefits associated with bone fracture is the reason why there are some protective effects from estrogen as far as avoiding postmenopausal osteoporosis. So that's really where we kind of got that from. So some risk, some benefit. I put at the time, and I think the FDA still recommends this, but the newest guidelines on menopause actually have gone away from this language. But I included both languages for you to know, essentially. But based on this, and remember I said before that trial, we had only the higher doses that were available. After this trial, the lower doses came. Because providing the lowest dose for the shortest duration needed to achieve the treatment goal was kind of what they recommended up until like 2017 when the new guidelines came out. So the new guidelines just kind of changed the language that says the most appropriate dose. So whatever the most appropriate dose is to reach your goals, that should be what you're looking for, while considering, of course, the risk and the benefits, right? Yes.
So, because we know that estrogen therapy can cause like clots and things like that, so will we now add like stroke prevention therapy, like anticoagulants or stuff?
No,
No?
not necessarily. That's just something that you need to be aware of.
Okay.
All right, so again, and I kind of restated this, but looking at risk and benefits, looking at your treatment goals, that's how you decide. That's how you individualize the therapy. So I mentioned time since menopause. So I'll kind of talk about that a little bit later. But again, everyone, I have menopause. It's been 12 months. Start me now. That's not always the case. Like I said, some people may try to say, hey, I'm gonna tough out these symptoms. I'm gonna try something else before you start the therapy. It may be time. The one thing that I do want you to know, about this, and I don't see it listed, maybe I put it on another slide. There are some guidelines, that we're looking at. All right. Remember I told you, 44 to about 58 or 40 to 58, something like that. 44 to 55 is the normal sweet spot for 95% of the patients. So then that means, let's say I'm 55. Let's just use that number. I'm 55 and I waited 5 years. I'm now 60, right? All right. So you want to take time since menopause into consideration. This cause of menopause is just saying, hey, is this a natural menopause or was this a surgically induced menopause? Okay, that's basically what that's saying. And then what symptoms that they're having. Okay, that's the way that you kind of make this decision. But here's where I'm going with that. The guidelines say, and this is something that you have to remember, if someone is greater than 60 years old of age, so one look at their age, but if they're greater than 60 years, or if their time since menopause is greater than 10 years, we don't want to use hormone replacement therapy. Okay? That's that patient group that's at the most risk. Okay? So an older patient, and then of course someone who their time since menopause is greater than 10 years. Because as I mentioned, one of the things that I did not mention, but I'll talk about it a little bit here when we start talking about osteoporosis. Once there was a benefit shown, right, in preventing fractures, and I'm like, hey, this is good. You're already taking it for menopause. you may as well keep on taking it for osteoporosis prevention, right? No, you're starting to see an increased risk at that point. So if their time period is greater than 10 years, that was the patient population where we saw increased risk. So remember those two things. I kind of alluded to this earlier, but lower doses, you said, hey, I need to reduce the doses on them. It provided equivalent vasomotor and vulvovaginal symptom relief. Okay, so those are our two goals that we were looking for. What about its osteoporosis benefit? Same thing. So you're not necessarily decreasing efficacy because you're lowering the dose, all right? You're doing that because of side effects. Okay, I talked about this as well, that you would want to use local therapy for vaginal symptoms. Lower doses may improve, your risk-benefit ratio. But this doesn't mean that just because you're on a lower dose that you can take it for longer, right? All right. I just gave you what the lower doses are for that, what we're talking about. I think I'm just mentioning this again. What about these non-oral routes? They're advantageous over oral. Actually, this is what the new guideline said, is that, hey, they're advantageous over the oral medication that has been demonstrated. But as far as in a long-term period, now again, what's the advantage over the oral? Non-oral over oral, what's the advantage?
It doesn't cause the side effects.
Huh? The side effects, right? So that's the advantage that we're talking about, not an efficacy advantage. We're talking about a side effect advantage. So there's not necessarily an efficacy advantage. It's just side effects that we're talking about. Again, one risk that we're talking about, again, I put this on the table that I'll show you when we're talking about the risk of DVT. It's possibly lower in the non-oral route, but the risk of breast cancer is the same. Okay? So by switching to a transdermal or you wouldn't switch to vaginal cream, I hope.
Yeah,
That's for vaginal symptoms, but switching to a transdermal doesn't mean that you're going to decrease the risk of breast cancer. Okay. All right. So I just restated what I stated before. So this is what I wanted to show you when we're talking about this risk, especially the cardiovascular risk. You guys are familiar with ASCVD risk, right? So when we're comparing our patients, of course, all patients aren't treated the same. It may not be in there. I'll update it to show you. I added this later. I talked about this already, but I wanted to kind of give you a picture. I also wanted to include the other two studies that help inform this information. So there shouldn't be anything new that I talked about on here, but I wanted to at least give you the numbers, what it looks like. So in a low risk patient, again, we're looking at low. I used that earlier, but you're talking about less than 5%. Hormone replacement therapy is okay, all right? Whether it's within the first 5 years or at a later point. But greater than 10 years, no matter what, greater than 10 years, no hormone replacement therapy, okay? So if it's within 10 years of onset of menopause, you can use it. But if it's greater than 10 years, don't use it. Because again, this is the patient population that we certainly saw increased risk of stroke, heart attack. Okay? So not greater than 10 years. No matter what. Low risk, moderate, or high. Not greater than 10 years. talked about that earlier. Then I talked about that transdermal may offer some benefit. That's someone looking in a moderate patient. So anyone with an ASCVD of 5 to 10%, you want to consider the transdermal. Low risk patient, you can use oral therapy or transdermal. But certainly, when they become moderate risk, that's when you want to switch them. When they're high risk, no. Okay? And we learned that post, even though WHI suggested certain things, 2 trials after that time, within the last 6 years, looked specifically at this and looked at timing, as well as this is what we found, there may be a dosage form improvement on our strategy. Okay? All right, any questions about menopause before we move on to osteoporosis? Think you got it? Think you may be able to individualize the therapy based on the side effects that you're seeing and the risk profile of the patient? Yes, no.
Would you like to provide
Some practice?
Yeah.
Yeah, I got some practice. Good idea. I got some practice. Yeah. All right, so let's talk about osteoporosis. This is a little video on it. I'm not gonna play it, but I think you should play it. It's a short video. But basically, like I said, you are familiar with osteoporosis already. So as far as the diagnosis of osteoporosis and the things that we'll find, it's pretty much the same. Our T-scores are the same when we're looking at osteoporosis in our diagnostic target. Of course, you guys know that there are 2 types. So I quizzed earlier, hey, can I get osteoporosis? Certainly, I can. All right, so what are some of the risk factors? So we know one of you guys said AIDS. You're a certain age, you don't get it. Now it's a risk factor, all right? So certainly as we get older, it increases our risk. What about body size or type? Hey, I'm getting quiet. Equally distributed, it's the same. Yes? No?
Yes.
Yes? It's the same?
No.
No? You're saying yes, it's not the same? She's like, yes.
I
Yes.
mean it's a risk factor. Yes, it's a risk factor.
Size is a risk factor? What's a risk factor? The larger you are, the more likely you're gonna get it?
No, it's about bone. The smaller bone.
Yeah, the smaller you are, the more likely you are to get it. So I don't have to worry about it. We've seen it more in Caucasian or Asian descent. And that's just when you're looking at the epidemiology, it doesn't mean, oh, I'm not Caucasian or Asian, I don't have to worry about it. Not true, not true. We know smoking and alcohol use, so some of the social history is important, family history is important. Chronic use of specific drugs, what does that mean? What kind of drugs? Huh? Proton pump inhibitors have been associated with increasing the risk of osteoporosis, whatever. There should be a big one that just jumps out.
Is it dental?
Is it what?
Dental?
So steroids, yeah. So steroids have been associated with it as well. So what can we do? So your goal here is prevention, right? So what we're talking about is how can we prevent it? So of course, exercise is important, particularly weight-bearing exercise. No, you don't have to become a He-Man or She-Ra. You probably don't even know who those people are. I don't even think they exist as heroes anymore. But they were big in my day. But you don't have to get big, but certainly weight-bearing exercise helps, right? But what we're talking about is calcium and vitamin D. Of course, conjugated estrogen are also used as well. Is that a high dose or a low dose? Huh? I gave you the doses earlier.
And I think that was that might be low.
Yeah, you told
It might be high, it might be low. I don't know. I'm asking you. You think it's high?
I think that was when you had reduced.
All right.
it's a high one.
So I used the wrong word. I probably should say normal, right? It's not high, but it's a normal dose, not a low dose, right?
It's not.
But did I say if you reduce it to the low dose, you'll have the same efficacy? Yeah. So that's just the normal dose that's used. It can certainly be reduced. It's not the only estrogen that is used. Other estrogen forms are used as well. Okay. Let's talk a little bit about calcium and vitamin D. This is all good information, but I'm looking at this is the one I'm looking for. All right. So these are kind of our daily intake requirements based on age. When you get older, the requirement. So can you take calcium and vitamin D now?
Yeah.
Sure you can, yeah. But the requirements as you get older increase both for calcium as well as vitamin D. Where does vitamin D come from? What's your from heaven?
Sunlight.
Big say it's coming from heaven, man. From sun, yeah, right. So it's coming from outside. So what's happening to our vitamin D levels during the pandemic?
Decreasing.
They've been decreasing, right? Yeah. So you've been having a lot of folks at risk of fracture because they've been cooped up on the inside. So a lot of physicians, have been just prescribing vitamin D to their patients, like, hey, you need to take this. All right, but we know that we get calcium from our food is our primary source, at least of our calcium. This kind of gives you, for those of you who can have dairy, what does 1,200 milligrams look like? From just getting it from your diet, as opposed to taking a calcium tablet. So I talked about this earlier, hint, right? Raloxifene is also used to prevent postmenopausal osteoporosis. What was the other one used for? All right. Okay. Another thing I want to kind of point out for you is we mentioned that estrogen and progestins can be a problem, but here's a combination where you can use that's indicated for osteoporosis prevention when you don't necessarily or want to reduce the amount of progestin or eliminate it altogether. So this is another estrogen combination therapy that's not with a progestin. You get what I'm saying? Will it prevent vasomotor symptoms?
It's like, yeah.
Well, you're like, it's there. Yeah, but what if I didn't put that there? Huh?
You still have to know.
You still have to know, but I'm saying, why would it prevent vasomotor symptoms? It's estrogen. That's right. Estrogen will prevent vasomotor symptoms. Okay, good. All right. Commonly used medication. It's not a trick. It's just a question. I'm preparing my questions. So I just want to know what's going to be good, multiple choice, good, select all that apply. I'm field testing. I'm just field testing. All right. Bisphosphonates. So we know that these are used as well. Bisphosphonates work very well But of course, bisphosphonates come with side effects, right? I put here, I just put in some notes, but again, I'm focusing on postmenopausal osteoporosis. But we also mentioned that you can have some steroid-induced osteoporosis, and what we found is greater benefit with risagenate and alendronate. But bisphosphonates, widely used for osteoporosis. They're the best products. But of course, they're associated with GI and esophageal side effects, right? You remember the counseling with these
Yeah.
items, right?
Mhm.
And I pop it in my mouth, go straight to bed.
No.
No?
You gotta sit up
So
for like
sit
30
up.
minutes.
Gotta sit up for 30 minutes, right?
Mhm.
Renal dysfunction is an issue with these medications. So depending on what the creatinine clearance is, you have to make some adjustments. But kind of some of the good things is that the new formulations, when these first came out, these were daily medication. Now we've developed doses for for weekly administration as well as monthly administration. So a lot of improvement in that way. Still comes with those side effects though, right? If I get more of it, there's even more of a chance that it can cause some of the GI or esophageal issues. So this has to be on someone that's compliant, right? That you're gonna try some of these higher doses. There is an IV formulation that can be used as well. But again, in renal dysfunction, severe renal dysfunction, we're gonna, it's gonna be contraindicated. But it certainly decreases your risk for vertebral and hip fractures. So they're very good medications. All right. So other medications that work on osteoblasts or osteoclasts, this is very commonly used as well. Both of these are subcutaneous, so these are not oral administration that are used. One of the benefits of Prolia is, its dosing frequency. So it's not weekly or monthly. It's twice a year. It's very effective as well. This one, of course, is daily administration. Calcitonin. Has anyone seen calcitonin or read about it?
Yes, it's a sin.
Is what?
It's a sin.
Oh, yeah, that's right. The cool thing about calcitonin is that, it has different administration forms that you'll see. You'll see a nasal dosage form. If you can't find it on the shelf, that's probably a good thing. It's in the refrigerator. It can also be administered IM as well. But I just put a little note here, not gonna be on the test, but just to let you know, it's also good for corticosteroid-induced osteoporosis. Again, we're gonna be focusing on postmenopausal osteoporosis. All right, so some of the same medications that you'll use in osteoporosis as far as preventing it work in postmenopausal osteoporosis. The thing is, so to think, all right, my patient has been on estrogen for menopause all this time, but it has benefits in osteoporosis, so we want to continue it. Not necessarily. You can change it to other medications that work very well in preventing osteoporosis. Some of them over the counter, right? Others are prescription, but certainly there are treatment options for it. Any questions for me before we head out of here? No questions? Huh? I heard somebody mumble something, but I couldn't make it out.
We went over a lot of postmenopausal drugs. I know for the last slide you said you don't want us to know, it's not necessary, or you just didn't want us to know that line.
No. Remember I said we're focusing on postmenopausal osteoporosis. So again, we're using medication Like I told you, this wasn't a whole thing on osteoporosis, and there are different types, right? So there are other medications that I just put a little line in there that it may be beneficial or more beneficial in certain types of osteoporosis. But yeah, you need to know that, but not for the test. All right, so Autumn asked for more practice. It wasn't me, but I was prepared for it because I had to think about what are the things that my students need, you know, that they may be asking for. So you ask for more practice, you'll actually be getting, it's gonna be one announcement. I'll put it all together, but it's really about two things. This is one of them. So we'll do a self-study assignment. So, self-study assignment. It's an open book.
Yes.
Open note?
Yes.
Open neighbor?
Yes.
Sometimes.
I
Sometimes.
heard yes, no, sometimes. Which one?
It depends.
All the above.
It depends.
Select all that apply.
Actually, select all the apply, yeah. So on your self-study assignments, you say self. So each individual has to turn it in. I actually don't care if you work together on it. I just don't want the same information. Okay? All I asked you for was a treatment plan. So I talked about multiple options, right? So do you need to know all options?
You should, so you know how to.
Yeah, that's a trick question. Yeah, you need to know all options. Do you need to include all options in your treatment plan?
No.
No. So don't tell me, oh, I was working with this person and we came up with the exact same thing. Then I'm gonna be like, why? Because you had other options, right? I'll ask you for one. And I did ask you to distinguish mild symptoms versus moderate to severe. So what would you do for mild symptoms? What would you do for moderate to severe? For each of these three scenarios. Sounds easy enough?
Can we talk about it?
Yeah, we're talking about it now. What questions do you have?
So for mild symptoms, I remember you said like, you can do like lifetime OTC.
And moderate to severe, you said severe.
I specifically said non-hormonal. We did have some others, right, that we mentioned that were non-hormonal that were only for moderate to severe. So non-pharmacological for mild symptoms, plus some other agents that might be effective, just not some of the ones that we talked about for moderate to severe. Okay? All right, so we're talking about two different things.
When is due?
I'm gonna send it out. I'll let you know. So, if for these three scenarios, are these the only things that we consider? Symptoms? No, right? So I didn't put any curveballs in there. I said first, just practice on the symptoms. What would you do? Symptomatology. What are other things that I said you want to look at? Okay. If they had a hysterectomy or not? Good. What else? Time frame? What does time frame mean? Time since menopause? Okay. All right. All right. Yeah, I see some cases developing in my head. Okay. All right. So, only thing I ask you to do for the self-study is do it based on symptomatology. But we know that there's more to it than that, right? So, for your notes, make sure that you understand how to do it based on symptoms, but hey, I can throw some other things in there that you may want to consider. So when you're distinguishing between which medications, remember I say you need to know all? Yeah, you do. You need to know in what scenario you'll use one versus the other. But I'm not asking you for that now, okay? But for your studying, you need to do it. All right, the other thing, that's just the homework associated with this particular lecture. I'll send it to you. When do you want to do? Friday.
Sunday.
Now I heard Friday. That's the first. That's the first time. Amen.
We got Oscars on Friday. We got Oscars on Friday.
Sunday at 11:59.
Yeah, Sunday at 11:59.
I was gonna give you Monday to 10 a.m. But
Monday right before we come back.
no. Sunday at 11:59. That's when y'all amen.
You said Monday, okay, so Monday.
Before we walk
sí, yo estaba.
That's what I was doing. I'll go and adjust the announcement. No?
The Lord led you to that, let him use you.
Okay, the other announcements, I said two. Nobody, like, what's the second one? The second announcement is we have readiness assessment. I think 7, 8, 9, right? I open those up too. Okay? Same thing. Same due date, if you will, for those. But again, those are just short quizzes. On it.
It's about this lecture.
Yes, I think this is 9.
So it would be the lecture from Monday,
If I'm not mistaken, I think 7 was,
what we did in class on Wednesday?
some of it, yeah. I think 7 and 8. So 7 was thyroid, I believe. 8 was what?
Like
What?
adrenal.
Yeah, it was adrenal dysfunction, drug induced adrenal dysfunction, right? And then, huh?
What about for Monday?
Monday is not included on this readiness assessment
Okay.
because, and I'm hesitant a little bit because one of the things that, remember, what we got moved around a little bit was as it relates to hormone replacement therapy. So it's really, I really want to hold off for a second. So I think what I might do is just open up 7 and 8 and not open up 9 because I want the hormone replacement therapy assessments to occur at the same time. And right now you talked about a little bit here, a little bit there, and you'll get another on Monday or Tuesday, I can't remember, when they're coming in talking about contraception and infertility. But when that happens, at the completion of that, then I think you have everything that you need to kind of talk about different hormone replacement therapy. So it may just be 7 and 8. I gotta go back and look at that and turn off 9. But you'll have at least those two. So somebody said, hey, what we talked about on Wednesday. Yeah, putting it all together, those two will be open for you. Again, over the weekend, it'll be due Monday by 10 a.m. All right? Questions, comments, concerns? Enjoy the rest of your day.